Okay, now it's broadcasting. Hello, everybody. We're just going to be starting shortly. As you are coming into the session, if you would like to put in the chat where you're from, we can read those off. I'm hearing feedback.
That's me.
Okay. We'll just wait another few minutes so that anybody else that may be joining us will get online. The session is supposed to start at 12 p.m. New York Eastern time, but 6 p.m. European time. We have some more people coming in. And we will be starting in just a minute or two. It's so great to have everybody on. If you'd like to put in the chat box where you're from, we can share that information as well. So I'd just like to introduce myself. I'm Dr. Josephine Grima. I'm the Chief Science Officer for the Marfan Foundation. I also have here my colleague, Eileen Michelli, who will be helping out as well. And I'd like to welcome everybody to the International E3 Summit. My slide is not forwarding. There we go. So we want to thank everybody for making this summit truly remarkable. It's by far the Foundation's largest event with nearly more than 2,700 registrants in more than from 72 countries. Additionally, there are people from many different related disorders, as you can see it here. Marfan syndrome being the largest group, almost 1,600 people. And even medical professionals have been joining us to share in many of the sessions that we have shared. We want to say thank you to our presenting sponsors, that is Brigham and Women's Hospital and American Communication Construction. Before we start the presentation, I just want to let you know that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or VASCERN. If you hear differences in opinions from speakers or want further clarification, you can please contact our help center at marfan.org/E3ask. At this time, we're having a large volume of questions, so please be patient and we'll try to get to your questions. So today we are very fortunate to have Dr. Jolien Roos-Hesselink with us. And we really do appreciate you coming and sharing your expertise with our membership. And if you'd like to just welcome our members here.
Yes, thank you very much, Jo. Well, it's an honor and a pleasure to be on this forum, and it's especially a pleasure to have the chance to talk about my big hobby, which is pregnancy and cardiovascular disease. So I'm very happy that you're here to join this session, and we'll first have the presentation, and afterwards it's open for questions, and very happy to ask and to answer the questions. But please note that I'm a cardiologist and not an obstetric trained person. So I'm really involved in cardiology. And also I cannot go into all the personal details. So it would be good to have your questions in a sort of general manner.
Okay, thank you. And let's, I just also, before we move on to the presentations, I'd just like to remind you to give us your feedback when the session is over. And you can start right here on the session app when you click on rate and then answer the survey questions. Your feedback really helps us to continue to provide more information that is important to you. And as Dr. Hesselink said, following the presentation, there'll be plenty of time for questions. So right now, I am going to, oh, I see we have Rolina here. Hi, Rolina. Rolina is a member of the Marfan Foundation from the US, and she has been very, very involved. And I think she would like to say hello to the participants as well, as she is also Dutch, correct?
Yes, hello. Look forward to attending this session, even though the subject matter doesn't apply to me directly, but most matters Marfan are of interest to me, and I've been enjoying this summit very, very much. It's a wonderful, wonderful vehicle to spread the information around.
Yes. Okay, thank you. Okay, so now we're going to go to the presentation. So I'm going to take everybody off video and mute.
Welcome to this short presentation on the issues to consider for patients with Marfan syndrome who are considering pregnancy. My name is Jolien Roos-Hesselink, and I'm a cardiologist working in Rotterdam in the Netherlands, Erasmus MC. And I prepared these slides also together with Dr. Yasso Emmanuel from the Guy's and St. Thomas Hospital in London. We are both part of the European Reference Network for Rare or Low Prevalent Complex Diseases, and in this case on vascular disease from VASCERN. To start with, all of you know that adults are not big children, and children are not little adults. However, if we are talking about sex, my most important part of this talk is that we have to discuss pregnancy in time and not at the age that we expect people to have children. This is a little bit older slide, but here you can see that already 16-year-olds are having sexual intercourse, and 25% of the girls and 30% of the boys are having sexual intercourse. So please discuss pregnancy in time. And as a doctor, it's very difficult if you have to take into account the situation where the patient is already pregnant. It is much better, much more convenient to discuss the risks of pregnancy, to consider prophylactic treatment if we are in a stable situation and not already in a pregnant situation. I had the honor to share the ESC guidelines for the management of cardiovascular disease during pregnancy together with Professor Vera Regitz from Berlin. And these guidelines were published in 2018, and they're the only worldwide guidelines on pregnancy. And we think that these guidelines are very important because pregnancy is complicated by maternal disease in 1 to 4% of cases. And one of the problems is also aortic dissection that can occur during pregnancy. Pregnancy has a major impact on the work that the heart has to do, on the heart rate, and a further increase is observed during labor. During pregnancy, there's a higher risk of heart failure, arrhythmias, thrombosis, and also on aortic dissection. In these guidelines, we discuss the classes of recommendations, and also we discuss the level of evidence. And for pregnancy, nearly all advices are only level of evidence C, meaning that there is consensus of opinion of the experts on small studies or registries. But it's very difficult to do good studies in pregnancy. Of course, there will be a lot of ethical problems doing a randomized trial during pregnancy. During the guidelines, we used the WHO risk classification to try and classify patients based on their risk. And a modified WHO class 1 is a low risk, no detectable increased risk. Class 2, there is a small increased risk. Class 3, significantly increased risk. And class 4 is an extremely high risk of maternal mortality or severe morbidity. And in these cases, pregnancy is contraindicated. Now, if we look a little bit more in detail, what does these risks mean? Class 1 is a very low risk, maternal cardiac event rate is low. But if you see in class 3, for instance, there is an event rate during pregnancy of 19 to 27%. So about 1 in 5 or 1 in 4 women will have an event and complication. And if you're talking about class 4, this is even 40 to 100%. So if you are in class 3, it is very important to have expert counseling, and also it is important to discuss in class 4 contraindication for pregnancy, and even termination should be discussed. And if you are in these high-risk groups, an expert center for pregnancy and cardiac disease is warranted. And this is extremely important because you really have to have the people, not only the cardiologist, but also the gynecologist, who are very experienced in the care for these patients. So this is a table where you can see the diagnosis. It's a very busy table. I don't want you to study all of these specific diagnoses, but this is just to point out that if you have moderate aortic dilatation in case of Marfan syndrome, so the aorta is above 40 millimeters, then you are in a class 3. And when there is severe aortic dilatation, for instance, the aorta is above 45 millimeters in Marfan syndrome, you are in a class 4 and pregnancy is not advised. So for these pre-pregnancy considerations, there are 5 main aspects to consider. The first is the risk of recurrence, and that is the risk of the baby inheriting Marfan syndrome. This risk is 50%, and some specific considerations are testing during pregnancy if the fetus also has Marfan, or even considering pre-gestation selection of embryos. The next consideration is the risk of an aortic event for the mother, both during pregnancy and during delivery. The third aspect to consider is the risk for the fetus. The fourth aspect is the risk associated with medications that may be used during pregnancy. And the final consideration is the risk for further progressive disease in the mother. So to go a little bit more in detail on the recurrence risk, there are 2 possibilities for considering pre-gestation selection of embryos or prenatal chorionic villus sampling. Prenatal chorionic villus sampling, PND, has the advantages that there's no artificial pregnancy, there's no need for hormonal stimulation, but by doing this investigation during pregnancy, there is a risk of fetal loss. And if you do find an abnormality and you want to put the following steps, it will be a high emotional burden of terminating pregnancy. For pre-gestational diagnostics, the advantage is that you have no emotional and moral issues related to terminating pregnancy. However, it's a technically complex procedure and you have to give hormonal stimulation. And this is not in all hospitals available. There are only a few centers that offer this possibility, and there are often long waiting lists. When you are considering pregnancy, we strongly advise that you see and discuss this with your cardiologist who know your case, and then please do it in time, so before you are really pregnant. We provide an overview of the considerations, but appropriate advice for you will need to be individualized according to your circumstances and personal history. As part of the pre-pregnancy assessment to determine the risks for you, we advise that you should have imaging of the entire aorta in order to identify whether they are abnormal areas that are dilated or aneurysmal that may be at greater risk of either dissection or rupture during pregnancy or delivery. This is usually performed using echo to assess the aortic roots and either MRI or CT scan to evaluate the rest of the aorta that cannot be seen easily using echocardiography. The assessment will also identify whether there are any other risk factors for an aortic event, such as high blood pressure, whether there has been any progressive dilatation of any parts of the aorta, and whether there is a family history of aortic dissection or rupture. If you're found to have high blood pressure, then it's important that this is addressed in order to reduce the risk of complications. And as well as assessment of the aorta, it is also important to identify whether there are any other issues that would be of relevance for pregnancy, such as spinal abnormalities that can occur in some patients with Marfan syndrome, and this may affect how anesthesia can be given during the delivery. And for instance, epidural anesthesia may not be possible in some cases if there are spinal abnormalities. Pregnancy, delivery, and the early postpartum period are known to be times of increased risk of aortic dissection and rupture. This is due to both the hormonal changes that occur with pregnancy, which lead to softening of the tissues, as well as hemodynamic changes in the cardiovascular system as a result of the increased circulating blood volume and the strains during delivery. If your aorta is particularly dilated or has grown significantly prior to considering pregnancy, sometimes we advise prophylactic surgical intervention before considering pregnancy in order to reduce the risk of aortic dissection or rupture. This is a very individualized decision, taking into account several factors, including the size of your aorta, whether there has been any growth in the size of your aorta, your family history, the results of genetic testing, and the short and long-term risk of the potential surgical procedures. The balance of risks for you should be discussed with your cardiologist, who may also discuss with the wider multidisciplinary team. Certain medication that are often used in patients with thoracic aortic disease are associated with an increased risk of developing fetal abnormalities. The most common of these are the ACE inhibitor and angiotensin receptor blockers drugs such as ramipril, lisinopril, candesartan, losartan, and irbesartan. This risk has to be balanced against the risk for the mother if the medications are stopped. We therefore advise that you discuss your medication with your cardiologist. If it's considered safe for you to stop your medication, then ideally this should be done 3 months prior to considering pregnancy. Sometimes a switch to an alternative is advised, but sometimes this is not very good possible. If you're taking beta blockers, then these should be continued, and some patients will even be advised to start on a beta blocker, for instance, instead of an ACE inhibitor or another medication that is not advised during pregnancy. Beta blockers most of them are safe, although we do know that the use of beta blockers is associated with a little lower birth weight of the baby. Some beta blockers like atenolol are not very well advised, and then often this medication is switched to an alternative such as bisoprolol, metoprolol, or propranolol. It's very important that your blood pressure is well controlled during pregnancy, and it should be maintained at less than 130/80. And it's also important that your blood pressure is regularly monitored during pregnancy, and if it's consistently above this level, then your doctor will advise on what additional medication may be appropriate. Where one parent has a genetically confirmed condition, this is associated with the development of thoracic aortic disease. There may be up to 1 in 2 chance that the baby will inherit the same genetic mutation. So the risk will be 50%. Pre-implant genetic diagnosis and selection and reimplantation of unaffected embryos may be possible, but you really have to discuss this with your team, who may refer you for further specialist discussion in other hospitals. This can be a lengthy process, so it's worth discussing this early with your doctor. Because of the risk of aortic dissection and rupture, our current guidelines advocate that pregnancy should not continue for longer than 40 weeks. So there's no use in being what we call overtime. Your obstetric and cardiology team will discuss with you about the balance of risks of induced delivery and the waiting for a natural labor to start depending on your individual circumstances. There's a slightly increased chance that your baby may be small, especially because of perhaps medication use, but also maybe due to your cardiac condition. During pregnancy, you have to be monitored, and often echo is used. Echo is safe, especially during pregnancy. There is no problem about that. And even sometimes MRI scans are important. The MRI scan can be done safely during pregnancy, although often this is not used in the first trimester. But the advantage of the MRI is that the total aorta can be visualized, while with echocardiography, only the first part of the aorta is feasible to see. And sometimes a CT scan may be necessary. CT scans are not often used during pregnancy because of the radiation, and radiation can be a disadvantage for the baby. But in some conditions, it may be appropriate, especially when the woman develops severe chest pain and there is a suspicion of a severe complication. And then a CT may be appropriate because the risk of a severe complication is then much more important than the small risk associated with the radiation. The frequency of follow-up is very important to discuss with your doctor, and this will be influenced by your situation. So if the aorta is dilated or not, if you have other risk factors like a high blood pressure or a family history of complications. So this will be a personal situation, based on the personal situation. It's very important that your condition will be discussed in the pregnancy heart team. At least members of this team will be a cardiologist, an obstetrician, and an anesthesiologist. But in some conditions also others are invited to join in the team, like geneticists, surgeons, pediatric cardiologists, neonatologists, pulmonologists, hematologists, or nurse specialists. This pregnancy heart team can be consulted already before pregnancy to discuss the risks and advice before pregnancy. And also when the woman is pregnant, often the pregnancy heart team is consulted between 20 and 25 weeks of pregnancy, because then you have a good idea of the current situation, and a plan will be made for the delivery. What kind of delivery? How long will the woman need to be in the hospital after delivery? Will there be specific medication needed or specific conditions? So everything will be discussed, and it will be made as a written plan available for everybody for 24 hours, 7 days a week. So, as discussed before, induction of labor should be considered at 40 weeks of gestation, because there is no use in being longer than 40 weeks pregnant. For many women, however, we will wait for spontaneous delivery. Only in some cases it's important to plan the delivery, but in majority of patients, vaginal delivery is the first choice. Cesarean sections, these are the indications, and one of them is aggressive aortic pathology. So for instance, if the woman has a very severe dilated aorta or already suffered from aortic dissection, then often a cesarean section will be planned. Endocarditis prophylaxis, so that means antibiotic use to prevent infection, is currently not recommended anymore for a delivery. Many women, including those with a mildly dilated aortic root, are still able to have a normal vaginal delivery. Some women are also able to deliver in their local center, but some women are advised to have their antenatal care and delivery at a specialized center. If the aorta is very dilated or has grown during pregnancy, then C-section may be considered. Your team will discuss the individual delivery plans with you at your antenatal visits, including timing and mode of delivery. This will take into account several factors, including the size of your aorta, the growth of your aorta, obstetric factors such as previous obstetric complications, breech presentation, placental issues, and geographic issues such as how far away are you from the hospital. Now I would like to share with you the results of our ROPAC study, because pregnancy is my absolute great hobby. I not only have 4 children myself, but I also have a great interest in pregnancy in patients with heart disease. And that was the reason for me to start, together with Professor Roger Hall from London, from the UK, the Registry of Pregnancy and Cardiac Disease, named ROPAC. And the goals of ROPAC were to assess risks for both mother and child, outline variation between different regions, to test and validate risk models, to support guidelines, to provide better advice to mothers. And we included pregnant women with structural heart disease, aortic pathology, and pulmonary hypertension. This study started already in 2007, and we entered a lot of pregnancies up to 2017. This was an international study, and we looked at all the details of pregnancy with a follow-up up to 6 months. We included data on the patient demography, the diagnosis, the obstetric history, home medication, the events during pregnancy, the delivery, the outcome, and also we tried to get information on the echocardiography and on the follow-up. In total, from 2007 to 2017, we had 138 participating centers in 53 countries. In green, you can see the countries that participated. And in total, we could include 5,739 pregnancies, all in women with some form of cardiovascular disease. Well, these were the main diagnoses: congenital heart disease, valvular heart disease, cardiomyopathy, ischemic heart disease, but also patients with aortic pathology and some with pulmonary arterial hypertension. In the results, we found that maternal mortality in patients with heart disease was 0.6%, so that is 100 times higher than expected. However, it might be lower than expected by other people. And we found heart failure as being the most prevalent complication in 11% of patients, and arrhythmias in 4% of patients. And these are the cardiac events, and we try to classify them grouped to the WHO risk classification that I showed before. And as you can see, the risks in class 1 and class 2 are very low, below 10%. In class 3, it is up to 30%. And in class 4, we found 50% of the women having a complication, most often arrhythmia or heart failure. And if we focus on the patient with aortic pathology, we had 217 women with aortic pathology, of whom 99 had Marfan syndrome, so that's nearly half. And from these women, only 4 had a complication, so that is 2%. 4% had an aortic dissection 3 times during pregnancy and one time in the first 6 months after pregnancy. And here you can see a table with the 4 patients. In 3, it was a proven Marfan syndrome, and in 1, it was suspected but not genetically proven. And here you can see the aortic diameter in the patients. In 1 patient, it was only 26. So this is to show that there is no safe diameter, and that even if you have a completely normal aorta, still there is a low risk of a complication. And in 2 patients, the aorta was very wide, 55 and 60 millimeters. And here you can see when the dissection occurred. It was 3 times during pregnancy at 37, 26, and 25 weeks, and 1 time it was 1 week after delivery. And here you can see also that 2 patients were using beta blockers medication, and 2 patients had no medication at all. The 3 women who had a dissection during pregnancy had a aortic dissection during pregnancy, had a cesarean section followed by surgical replacement of the aorta. No maternal mortality occurred and no fetal loss, so that is very important information. In the ROPAC study, we also looked at the mode of delivery. And the question was, is a planned cesarean section in women with cardiac disease beneficial? And well, of course, you first have to look at the background ratio of use of a cesarean section, because that differed enormously between the different countries. For instance, in Italy, if you look in the normal population of women, 40% have a cesarean section. And in the United States, this is over 30%. While if you look at the other side of the spectrum, in the Netherlands, my country, this is only 14% that is having a cesarean section in the normal population. And in blue, you can see the use of cesarean section in cardiac patients. In blue, the results from the ROPAC, and in red, it was the normal population. And you can see that in all countries, the use of cesarean section is much higher, but also there's a great variety between countries. And these data suggest that a planned cesarean section does not confer any advantage over planned vaginal delivery in terms of maternal outcome, but is associated with an adverse fetal outcome. That was the result of this study. The ROPAC is still continuing, and we focus now only on patients with aortic pathology or on patients with a prosthetic valve. So if any of you wants to join in this study, in this prospective registry, you're very welcome, and I would really welcome you to send an email or a message to this to our organization. Thank you very much. The period of increased risk of aortic dissection and rupture continues into the early postpartum period until the hemodynamic and hormonal changes have resolved. This can take a few weeks. A follow-up assessment of the aorta is advised in the first few months after pregnancy to look for any late changes in the size of your aorta. Some medications are excreted in breast milk, and therefore the fetus may be exposed to this if they are breastfed. We advise that you discuss with your doctors about what the balance of risk is between the potential benefits of the medication for the mother and the risks of any medication for the fetus. Sometimes neonatal monitoring may be necessary. So in conclusion, the most important message of my talk is that pre-pregnancy counseling is crucial. Discuss already pregnancy before you are actually pregnant. Discuss the risks for the mother and the baby, the inheritance risk, medication, and the long-term expectations. Use the pregnancy heart team, both pre-pregnancy when there is a pregnancy wish, and also to prepare a plan between 20 and 30 weeks for the delivery, including the postpartum period. And pregnancy should not exceed 40 weeks. And vaginal delivery is first choice in most women. Thank you very much for your attention, and happy to answer any questions or remarks.
Thank you so much. That was a wonderful and very comprehensive session. So let's go to the Q&A box and see if anybody, what questions have come in that we can answer. And the first one was submitted by somebody named Valerie, and she's asking about cyclic vomiting syndrome associated with Marfans or other CTDs. And I think this type of question is really not part of your specialty, so I think I'm going to ask Valerie to send that to us at marfan.org/E3ask. And we can get a probably a gastroenterologist to answer that question. So let's go down to the next question. What is the recommended management for pregnancy in someone who has had aortic arch and descending aortic repair, but still has a medically managed abdominal aortic dissection? Not becoming pregnant is really not an option, regardless of high-risk status. IVF, pre-implantation, and surrogate are also out of her budget. Do you want to comment on that?
Yeah, well, I think it is a very good question. However, it is difficult because it says not becoming pregnant is not an option. So if I would counsel Jessica, I would say, of course, your risk is high and you are in the WHO class 4. So I would advise you not to become pregnant. However, I always say to my patients, if you still want to become pregnant, I'm going to help you as good as possible. So what you should do is go to your cardiologist, talk about medication, have a good follow-up during pregnancy, if you actually do want to become pregnant, but you have to consider that your risk of having a complication is about 50%, and there is a risk that you will not survive. So you really have to be aware of that. And if you still want to continue, find somebody who is really willing to guide you through the pregnancy. And yeah, you should have a real intensive follow-up in a very tertiary center.
Okay, thank you. There is another one here from Valerie, who I also think may be more suited for a gynecologist. So again, maybe she can send that to marfan.org/E3ask on our website. There is one here by Hubert. What is the frequency of uterine or aortic aneurysm rupture during labor in Marfan, maybe, and LDS?
So we know that especially patients with vascular Ehlers-Danlos loss, they are at risk of suffering from uterine rupture. For Marfan and Roos-Hesselink syndrome, the risk seems very low, but of course the risk of aortic aneurysm, we know that pregnancy is probably a high risk period, as I explained, due to the hormonal changes, the softening of the tissue, and also due to the hemodynamic burden of pregnancy. We know that especially in the 3rd trimester of pregnancy and also in the postpartum period, the risk of rupture and dissection is higher than outside pregnancy. And of course, it depends very much on the size of the aorta, on the underlying disease. We think that Roos-Hesselink is at least as a high risk as Marfan, and maybe even higher. So I think that the risk of rupture must be seen higher during pregnancy than outside pregnancy.
Okay. This is submitted by Rachel. At what aortic size would you recommend having prophylactic surgery to repair the aorta before getting pregnant, specifically for LDS?
Yeah, that's a very good and very difficult question. And this is really an area that we do not have good data. There are some case reports that you can even have a dissection after surgery for repair of the aorta. So if you repair the ascending aorta, you can still suffer from dissection in the aortic arch or in the descending aorta or in the abdominal aorta. So therefore, it is very difficult to recommend prophylactic surgery. It was in the old guidelines, but now in the new guidelines, it's sort of not specified anymore because we know that also after surgery, you can have a dissection. However, for Roos-Hesselink, if you have a family history of dissection or somebody in the family already had a aortic complication, then certainly I would operate on a diameter of 45, even maybe 40. And for Marfan, it also depends if you have a positive family history, but I think also about 45, then prophylactic surgery might be indicated.
Mhm, mhm. And then when you do have the surgery, how safe is it to have the pregnancy after that?
Well, we always advise to wait for at least 6 months after surgery because the body has to recover, and you should be really in a good shape to start with pregnancy.
Mhm,
Some even advise 1 year after surgery.
mhm,
So you're totally in a good shape before you become pregnant.
mhm.
Um, and again, we are not completely sure that after prophylactic surgery, pregnancy is completely safe,
Okay.
because you can always suffer from dissection in another part of the aorta.
Yes. Okay. Thank you. Um, so in regards to, where did that go? In regards of risk of children inheriting the syndrome, is there a procedure or way that can guarantee that my child won't inherit Marfans, for example, IVF? And how long is the process in this case? And I think you did go over that a little bit in your talk, but maybe you can reiterate a little bit on that point about what IVF involves and what
So
the options are.
this is what they call a prenatal diagnosis. So what we do then is that we give hormonal therapy, and for the woman, some eggs will be gathered, and in the laboratorium we select an embryo or an egg without the Marfan genetic disorder in the fibrillin gene, and in the lab there will be a IVF done, and then it will be so the pre-selected embryo will be put back in the woman.
Mhm, mhm.
And you can have a normal pregnancy, but of course this is quite difficult and quite expensive.
Yes. Okay. Another question, when we think about surgery, is there one aortic surgery that might be better than the other before pregnancy? For example, composite graft or valve sparing? I mean, which would be preferable if they could get both?
Yeah, well, of course, if you could try to prevent having a valve replacement, that would be the best option, because especially a mechanical valve is associated with problems during pregnancy, because then you need good anticoagulation. And we know that during pregnancy, the normal anticoagulation, the vitamin K antagonists, are not safe for the baby. So, or you have to take it with the higher risk of miscarriage and a higher risk of having an abnormality in the fetus, or you can switch to low molecular weight heparin, but we know that it is not completely safe for the mother. It's not optimal if you have a mechanical valve.
Nice.
So a mechanical valve really is not ideal during pregnancy. So if you could prevent that by having a valve repair, of course, that is much better.
Right.
You can
And
also
that's
use for a biological valve, but then we know that these valves will have deterioration. So in about 10 to 15 years, you'll need another surgery to have another valve again.
to have another
Replace
replacement.
the valve.
Yes.
Yeah.
And how about having multiple children? Is there, once you have one, and is there any contraindication for having multiple children? And or is it that you still just have to keep checking your cardiac status after each pregnancy?
Yes, so indeed, although you have one successful pregnancy and a healthy child, if you want to have another baby, I think it's again very important to see what is at that moment your situation. So you have to consult the cardiologist and see how is your aorta, how are your other, how is the situation, is there any valve regurgitation or whatever. And so every time again, I think it's very important to have counseling and discuss the risks of a next pregnancy. I also would like to stress that in some women, it is well possible to have more children. I think it is as important to point out that pregnancy is a risk in some high risk patients. And on the other hand, in some women, don't be too afraid, and please do start your family if you want, because I know that is so important, and sometimes it's well possible.
Okay, that would be great. And how often do you think women that are pregnant should visit their cardiologist, and how often should they get scanned during pregnancy?
Well, it depends, of course, on the size of the aorta, and if there have been any complications in the past, and if there's any high blood pressure or family history. But typically, if you are in a good situation and the aorta is not dilated, I think maybe only 2 or 3 times during pregnancy you have to see your cardiologist. So not too often. And only if you really are high risk, then you should come more frequent, maybe every month, and have an echo. And if needed, you can also have an MRI. Preferably, you could have an MRI before pregnancy, but also it's well possible to check the aorta during pregnancy with an MRI. So it varies a little bit between 2 to 3 times during pregnancy, up to maybe every month.
Oh, wow. Okay. All right. Well, thank you all for those wonderful answers to those questions.
It's really a pleasure. And if there are any other questions left, I'm happy to answer them also after this talk. So.
Okay, thank you. We would very much appreciate that. So just some final thoughts here. We just want to remember that we would love to have your feedback on the session, and you can complete that in your Hubert app. For those questions that weren't answered, we do ask that you submit them to marfan.org/E3ask. We have many exhibitors in our virtual exhibit hall, so you can take a look at some of the things that we are offering. If you connect with your community, you can connect to your community within the app or on social media. You can use the hashtag E3Summit20. And if you can help us to make more programming possible, you can always also donate at marfan.org/donate. So we want to thank you very much. Thank you, Dr. Roos-Hesselink, for all the information. It was really valuable to our membership. And thank you again.
Thank you.